morning and welcome to this webcast on pelvic venous disorders, discussing some of the best practices for the management of these complex disorders. We have an illustrious panel of speakers this morning listed here. Stephen Black from London, Kathleen Gibson from Bellevue, Washington, Neil Kilnani from New York, Gloria Salazar from Boston, and myself from the University of Washington. These are everyone's disclosures of their conflicts of interest. So the learning objectives of this webinar are as listed here: to identify barriers and access to care for pelvic venous disorders and potential solutions to the patient who's presenting with a pelvic venous disorder, to understand applications for embolic agents in the treatment of pelvic venous disorders, and to understand the recent progress of the International Pelvic Working Group, both for the classification and the treatment of pelvic venous disorders. And with that, I'll turn the program over to Dr. Neil Kilnani from Weill Cornell School of Medicine in New York, who's going to talk about barriers to access to care.
Thank you, Mark, for the introduction, and thanks to Medtronic for giving us the opportunity to speak about pelvic venous disorders. We think this is a very important topic, and I'd like to point out that they had no influence at all on the content. My topic is the barriers to pelvic venous disorder access to care, and we like to point the finger at the payers and say that the payers are the main barrier to our being able to deliver the care. And certainly this has been written about in the past. When we look at the carrier policies, there's no question that the carriers are not supportive of this. Many of their comments are that there's no evidence, it's experimental, and things of that nature. And they've even gone so far as to solicit outside support to affirm their statements that this is all experimental by reaching out to companies that do technical assessments but don't even allow those technical assessments to be distributed to the physicians and the patients who are impacted by them. So with that, I just wanted to take a moment to go through what the data is and to see what the validity is to the comments made by the insurance industry. Between 2014 and 2018, there were 4 separate systematic reviews done to look at embolization for the treatment of reflux in women with chronic pelvic pain. All 4 of them came up with very similar results. And so what I'm going to do is focus in on one by Dr. Daniels, published in 2016 in JVIR. In that and in the other studies, consistently, there was the demonstration that 75% substantial pain relief was identified when you used the visual analog scale after embolization for pelvic reflux. This was associated with a very low reintervention rate and very low complications. However, all 4 systematic reviews identified low quality evidence. 21 of the 22 studies that all the groups identified were retrospective case series. There was 1 flawed RCT. And one of the problems with these data is that it was very heterogeneous to the point that they couldn't even do a meta-analysis. And the heterogeneity existed in the diagnostic criteria for the disease, the techniques used and how those techniques were reported, the endpoints that were used to define success and failure, and the various outcome tools were very different from study to study. And none of them were patient-centered. When you apply the grade criteria to this particular data, and this was done by Dr. Daniels, it was classified as low quality evidence. And just to show you what low quality evidence means, or actually very low quality evidence means, it means that there's very little confidence in the estimated effect. The true effect is probably very different from the estimated effect. And so we do have another challenge, and I think the second challenge is more important. It may be based in the same issue, but it's convincing our gynecologic colleagues. I think, if you were to look at the percentage of patients that the insurance companies are functioning as gatekeepers, it's just a small fraction of the potential population that could be treated for pelvic venous disorders if we could prove that there's benefit to this treatment. And so just to look at a March 2020 American College of Obstetrics and Gynecology Practice Bulletin, these are their guidelines. These are the documents that they're working gynecologists follow. And if you look at the statement, pelvic congestion syndrome is a proposed etiology. Although venous congestion appears to be associated with chronic pelvic pain, evidence is insufficient to conclude that there's a cause and effect relationship. And they go on to say there's no consensus that there's any benefit from treatment. And I just want to point out who the author is. The lead author of this paper is Lee Learman. And I wanted to share with you in the audience that Lee has been part of a work group that Mark is going to talk about in just a moment, trying to advance the evidence here. And I just want you to see that the gynecologists aren't necessarily all being obstructive. I think they're interested in trying to help the patients with the best things. So I'm going to just play a little clip.
Over the past several years, I have supported the American College of Obstetricians and Gynecologists, ACOG, in their collaborations with the American College of Radiology and vascular specialty community to identify the role of pelvic venous disorders in chronic pelvic pain. When I was co-authoring the ACOG Practice Bulletin, there were so many gaps in the scientific literature that we could not offer helpful guidance regarding the role of pelvic venous disorders in chronic pelvic pain. The work you are doing is incredibly important.
So to conclude, certainly the primary barrier in this particular case is not a them. It's not the payers and it's not the gynecologists. Ultimately, it's the evidence. And this is something that we as a community are responsible for developing. And as a lead-in, I'd like to introduce Dr. Meisner, who's going to talk a little bit about a work group that's been formed to try to address some of these evidence gaps. Mark?
Thanks, Neil. That was a very nice talk and fits nicely in as a segue into my talk, which is going to talk about some of the work that's being done to advance the evidence base for the management of pelvic venous disorders. Pelvic venous disorders, as Neil talked about, aren't commonly accepted in the general medical community, and in particular in the gynecology community, and the benefits of intervention, as Neil discussed, really aren't uniformly accepted. And this has several causes rooted in the limitations of the published evidence. Most importantly is the non-specific historical nomenclature, such as pelvic congestion syndrome, variable and imprecise diagnostic criteria, and the lack of rigorous randomized trials, and even the lack of the tools such as appropriate patient outcome instruments to perform those trials at this point. With this in mind, in order to bring some clarity to the field, the Society for Interventional Radiology convened a multidisciplinary group in October of 2017 to identify some of the research priorities in the management of pelvic venous disease. And among the 5 priorities that were identified, second among these was to develop a discriminative instrument similar to SEEP for the classification of pelvic venous disorders. And the third priority was to develop a quality of life tool that could be used to actually initiate starting randomized clinical trials. And I would like to say that this group has made very good progress along this. Unlike many groups that are formed to tackle a disease process, I think everyone's very proud of the work that's been done by this working group. The second priority has now been met with the development of a discriminative classification instrument known as the SVP instrument that was published just this month in the Journal of Vascular Surgery, Venous and Lymphatic Disorders. And unfortunately, I don't have time in this talk to go through this in detail, but I'm just going to provide a brief overview of the SVP classification. It includes 3 primary domains: symptoms, the involved variceal reservoirs, and similar to the SEEP classification, the specific classification of S and V are designated by subscripts to S and V. And both of these are divided into 4 anatomic zones based upon the involved the pelvic venous circulation and the involved variceal reservoirs, extending from the top, zone 1 at the left renal vein, and renal hilar varices down to the zone 4, which is the lower extremity and lower extremity varices. Finally, the third domain is pathology, and this is exactly analogous to SEEP, where the precise anatomy, the hemodynamic abnormalities, whether due to reflux or obstruction, and the underlying etiology are classified under this P domain of pathophysiology. The patient's final classification is as shown here with subscripts for symptoms, varices, and the individual components of the pathophysiology, anatomy, hemodynamics, and etiology. Now, pelvic venous disorders are complex, and this manuscript has to be gone through a few times to fully understand it. But to assist in the adoption of the SVP instrument, the American Vein and Lymphatic Society has developed an app that's available both on Apple and Android platforms that consist just of simple checklists that generate a final SVP classification. And I think everyone who's used it to date finds it very easy to use. And if you're interested, this is available for download on the American Vein and Lymphatic Society website as shown here. The second priority was the development of a patient-centered quality of life outcome tool that will be the start for outcomes in randomized clinical trials. And this third priority is now well underway under the direction of Neil Kilnani as the leader. And it's going to use standard psychometric methods in developing the instrument, and the preliminary validation will be in a population of women before and after treatment for pelvic venous disorders, and hopefully we can expect this within the next year or so. And the final priority is to actually proceed with the development of randomized clinical trials. And if you do a search of clinicaltrials.gov, there's currently only one clinical trial throughout the world that's listed. This is a randomized clinical trial from Uruguay that's randomizing 120 women to either intervention or conservative management, which will include phlebotomic agents. And this is tentatively scheduled to be completed in October of 2022, still a ways off. However, randomized trials are underway in the United States as part of this pelvic venous working group. Currently, a trial is being planned by Ron Winokur and Neil Kilnani. This is a small trial that's going to randomize women to either venography and pelvic venous embolization, or venography alone with best medical management. And the primary outcomes are going to be visual analog pain scores and change in generic PROMIS scores. So in conclusion, there is a general lack of acceptance in the medical community and in the gynecology community in particular regarding the relevance of pelvic venous disorders. And this is largely because of a lack of robust evidence supporting intervention. But I think we're making very good progress over the past 2 years in generating the framework that can be used to develop this evidence, including the development of the discriminative instrument, the SVP classification for patient selection, as well as robust patient-centered outcome measures. Thank you very much for your attention this morning. And with that, I'll introduce our next speaker, who is Gloria Salazar from Boston. Welcome, Gloria.
Thank you very much for the invitation to be part in this panel. I'm going to be switching gears a little bit to a more practical approach here. These were excellent points presented earlier, and I'm going to bring us to clinical practice, presenting a case with chronic pelvic pain with pelvic reflux. So as explained, this is not a one-size-fits-all disease. There are many things and many anatomical points that can be involved in the management or in the workup of those patients. Today, I'm going to focus a little bit more on the reflux side of it, and particularly the ovarian veins. This was already shown. And when I talk to my patients about these procedures, I usually tell them exactly what we just discussed earlier. There's no sufficient data. There's no high quality data. However, we do know that in spite of variation of the data, patients do experience 75% substantial pain relief. And this is a timeline that I wanted to show because we evolve or we change as a group historically to just treat one vein, and then moving on more recently to treat 4 veins, both ovarian and internal iliac veins. So I think that speaks to the variation and heterogeneity of our techniques. So I'm going to present a case of this 38-year-old woman who had 3 children, and she has had chronic pelvic pain for about 7 years. She has been managed all along by gynecologists, and she also has headaches that feel like pressure. So the way that she describes the pelvic pain is that something is coming out of the uterus, and she explains that's having a headache in the uterus, so it's the pressure. Upon interview of this patient, I found that she has what I call the 3 Ps, which I think are pretty associated with pelvic venous disorders. She has chronic pain that is postural, basically is relieved by laying flat, and postcoital pain that lasts for a couple of hours. And I think to me that speaks very highly of this diagnosis. In addition to that, because she was treated for 7 years by gynecologists, she had all sorts of treatments with hormonal treatment and IUD. And all along, they always perform this transvaginal ultrasound where you can see significant dilatation of peri-ovarian veins or ovarian veins with crossing vessels in the uterus, which I think, again, is pretty indicative of sort of pelvic venous disorders right here. So to me, after the evaluation in clinic and with this transvaginal ultrasounds, I took her to clinic and into procedure and to evaluate her pelvic pain. So what I found is that she has bilateral ovarian vein reflux with significant pelvic varicosities and the periuterine plexus. You can see here from the left side. And then also I went from evaluating her iliac vein, which we're going to talk later in this webcast. And she had stenosis, and here are the IVUS images for the stenosis. So these were done at different times. So I'm going to put it all together for the SVP, and I'm hoping I did this right because I did not have the app at the time, so I had to read the whole paper. And that's the final classification for her. She only had symptoms in her pelvis, so zone 2, varices in the pelvis, and she has reflux in both ovarian veins, internal iliac vein, as well as obstruction or stenosis in the left common iliac vein. So I hope I got it right. And so my intention was to stage these procedures. And the first part that I think, vary a lot in our technique is whether we should treat the pelvic reservoir or not. And I have to say, over the years, I feel like very strong about treating those periuterine varices. This is another patient that I treated. And usually I do this with foam sclerotherapy, but you can use all sorts of different agents. So I started with that, and then in the first procedure, I tried to just tackle the left ovarian vein. Again, my approach is stage approach. I don't do all procedures at once. I want to kind of understand how patients improve. And my preferred technique is sandwich technique with coil and foam with 3% Sotradecol. And then midway or in the upper third of the ovarian vein, then I'll just use a large detachable coil to close it off about 2 centimeters from the origin of the left renal vein. So she did well, but she did have significant allergic reaction in the lower abdomen and the distribution of the pelvic area. And so I attributed that to a basically allergic reaction to Sotradecol. So when I brought her back for a second procedure, I elected to just do coils. And for me, the challenge was to really kind of pack that large vessel territory with coils alone. And in retrospect, I could have used other agents, but I was just like, she had significant delayed reaction that we had to treat with steroids. And so for this procedure, I elected to use very large coils with long coils. So I used 3 large coils here to close off the ovarian vein on the right side. And my approach was transfemoral because I wanted to also place a stent, which I'm not going to show here. I know that we're going to have a discussion about that. So interesting enough, in the first procedure, she did not have 100% improvement. She actually reported that symptoms improved on the left side, but then she had more symptoms on the right lower quadrant and the left thigh and groin. And so in the second procedure, she 2 months after the second procedure, where I actually embolized the right ovarian vein and placed a stent, she reported 100% improvement. We're still going to continue to follow up with her and see how she does. And this is just a simpler case where bilateral gonadal vein or ovarian vein reflux. And I ended up doing sandwich technique, and she's now 2 years out with 100% improvement. She's about same age of the previous patient. So I'm not going to present this. This was already shown, 75% improvement, these different studies. And then in conclusion, for me, there are different presentations of this disease. We need to be able to do proper diagnosis and patient selection and talk to the patients, explain this is a complex disease that I think helps with the outcomes and also reassurance of the patients. For me, we should treat pelvic reservoir with liquids. In the case of, in my situation, 3% Sotradecol with foam. And I usually do transjugular approach if I'm going to treat the ovarian veins. In the internal iliac veins, I elect transfemoral balloon occlusion. I didn't show it in here. And large coils with long lengths do help to pack the ovarian veins. So this is what I wanted to present, and now I'm going to move this webinar to Dr. Kathy Gibson at Bellevue, Washington, who's going to be presenting on pelvic origin varicose veins. Kathy.
Thank you, Gloria, for that introduction. So I'm going to present to you a patient with a little bit different patient presentation. She also has pelvic source varicose veins, but does not have symptoms in her pelvis. So this is a 40-year-old pediatrician. She came to me with 2 years of symptoms of intense vulvar itching, and in fact had been treated with anti-yeast medications multiple times. She has vulvar heaviness and fullness and no pelvic symptoms. She's had 2 previous pregnancies of large infants and is an otherwise healthy woman. This is what her leg and vulva looked like on physical examination. So a little bit more on the left side than the right. And this is a varicose vein map. And in our clinic, pink is reflux. And she's got a 5.4 centimeter vein in the vulvar area that goes down her medial thigh, joins the GSV. Her saphofemoral junction and anterior saphenous vein are competent. And then she has these segments of incompetence in her great saphenous vein without varicose vein branches coming off of it. And she also has an incompetent saphopopliteal junction with no varicose veins coming off of this area. So she had a transabdominal duplex exam, and this is what we do in our lab. We don't do cross-sectional imaging very often. And this showed a number of different notable findings. So we found that she had a compression of her left renal vein visually with a velocity ratio in this area of 3.8. She had bilateral common iliac vein compression visually, and velocity ratios 3.8 on the left, 1.8 on the right, over 2.5 we consider to be significant. So more significant on the left side, and we also saw some collaterals in this area. She has a large refluxing ovarian vein. It's 11 millimeters on the left side. Her right side, the ovarian vein, is 6 millimeters, and it is not refluxing on our ultrasound. So using the SVP classification tool that Dr. Meisner mentioned, this again, you can find the link on the AVLS website. It's available for Android or iPhone. So I'm going to show how to classify her using this system. So her symptoms are vulvar. That's where she has her symptoms, none in the pelvis or the leg. So that would be an S3A. So the zone is the vulva. She did have visible varices in the pelvic area and in the vulva. So her classification for V, where the varices are, is 2, pelvis, 3A, vulva. And then the P of the SVP has 3 components or subunits. One's anatomy. So we click all the different veins that are involved. So left renal vein, left ovarian vein, both common iliac veins. We did not see reflux in the internal iliac veins on ultrasound. It's possible that would have been demonstrated if she'd had venography. And then pelvic escape veins. And then the hemodynamics, you classify as either obstruction or reflux. And then the etiology, whether it is thrombotic, non-thrombotic, or congenital. So this is an example for the left renal vein. It is obstructed and non-thrombotic. The gonadal vein, the left gonadal vein is refluxing, non-thrombotic. The common iliac veins bilaterally show obstruction, non-thrombotic. And the pelvic veins on the left side show reflux, non-thrombotic. We did not see vulvar veins on the right. Or actually, this is wrong. This is bilateral here, but I clicked left there. So this would be her total classification, and the very last one is cut off. That would be pelvic reflux non-thrombotic. So these are just a few pictures from her scan. She has a compressed left renal vein on exam. And that shows the SMA over the renal vein. This shows her right common iliac vein compression and her left common iliac vein compression. This is her ovarian vein. So how do we treat her? You know, there's a lot going on here. These are different options that you could do without talking to her. So not that you should not talk to her, but say you saw this patient in a vacuum and didn't know what her symptoms were. Possibilities of treating what you find on ultrasound could include embolization and sclerosing the left ovarian vein or both ovarian veins, transposition or stenting her left renal vein if she was having flank pain or hematuria, dealing with her compressed iliac veins. You can treat or embolize the pelvic veins from the bottom up, or you could do nothing. She does not have a life-threatening problem. So what if we were to treat her vulvar veins from the top, do coil embolization? What's the data there? There's not a lot of data about what that does to vulvar veins or veins in the leg. There's 3 studies that I've found. And if you look at them, they're treating patients with perineal symptoms or atypical varices. And some of the outcome measures are things like elimination of reflux on transvaginal ultrasound. So that really isn't measuring anything at the first study about patient outcomes. They found that there was 84% elimination of reflux, but in doing this, we don't know how the patient's vulvar symptoms did. And 2 patients had coil embolization to the lung and 1 to a common femoral vein. The second study, only about half of patients had good results from that and no recurrence of their vulvar symptoms when treated from above. And in the third study, 82% of them still needed to have treatment from below after they had coil embolization. We actually have not a lot of data of treating from below either. There's a paper in Russian that treats 59 women from below, and their results are this scale of excellent, good, satisfactory, and unsatisfactory. And then a few case studies are published. However, I do really think that protocol is the best, the treating from the bottom if the patient has no pelvic symptoms, and this is my protocol. So if a patient comes to me with vulvar varices and is asymptomatic or minimally symptomatic, and we don't have to treat them. This is not a dangerous situation. It's a lifestyle impacting one. If they're symptomatic and their symptoms are predominantly pelvic, and they happen to have vulvar veins, but predominantly complain of pelvic symptoms, I treat them from above, much like Dr. Salazar did with coils and sclerotherapy. If they have no pelvic symptoms and their symptoms are all in the vulva or leg, I start by treating with sclerotherapy from below. And I do this in my office. Patients are warm and well hydrated. I usually have a vascular tech helping me. And this is because sometimes with loose skin in this area, it helps to have an extra set of hands to kind of stabilize the veins. I use a butterfly needle, typically a 25 gauge with polidocanol foam from below. And this is a little video of me getting into a vulvar vein with a needle. So this is the patient after treatment. And I should say that another alternative to treating from below is using fluoroscopy. And I know some people do this. They inject contrast from below and gauge the volume that's needed to treat. I found that unnecessary to do in our lab. I find that ultrasound works and that I don't need to go to the step of having radiation with fluoroscopy, but I think either approach is fine. So this is the same patient after treatment, and she got very good results of her vulvar itching with a single session of sclerotherapy from below, and this has not recurred. I did not need to treat any of her saphenous vein incompetence. That was, quote, an innocent bystander. She did not have varices coming off of her great saphenous vein. And kind of my takeaway from this is you don't have to treat the ultrasound image abnormalities or findings. Treat what is bothering your patient and really listen to what their goals are. So a few other cases of treating from below are shown here. Here's a patient before and after treatment of her vulvar veins, another one. And this is her leg after. And so we, a number of years ago, did a paper on 72 women that presented with vulvar varices, and we were looking at what symptoms they presented with to see kind of some other things like body weight, other issues. And of this 72 patients, I tracked them for several years, and 15 of them elected not to have treatment. And this is foam from above. 51 of them were treated, and I had follow-up out to 2 years. 6 of them, I did not have that long-term follow-up. And I found that 68% during the 2-year period had resolution of their symptoms. And one of them had recurrence where they had sclerotherapy at about 24 months. Of the 15 who had improvement and not resolution, 7 of them required no further treatment, 6 had another session of sclerotherapy, and 2 of them went on to coil embolization for recurrent symptoms with some pelvic component. So of the 72 patients, they did very well with this algorithm of treating from below. So when do I treat from the top down? Again, when the primary symptom complex is pelvic, low back pain, heaviness in the pelvis, pain with intercourse, and also worse with menses often. Failure of treating from below, I will treat them from above. Like if they have an early recurrence, then I will, like the 2 women that I ended up treating in the other group. So some unanswered questions we have is we don't know which approach gives the greatest improvement in symptoms long-term in patients. Again, our data is not very good. We don't know how often leg and vulva symptoms will go away with coil embolization alone, other than the data that I showed you before, which again was not really high quality data. We don't know when these recur or what the expected recurrence rates are. And we don't know that if you treat them both ways, like treat from above and below, does that decrease recurrent rate? We don't know. Which approach is most cost effective? I think from below is clearly. Are there clinical criteria that we can develop to tailor the treatment? Can we predict which patients will recur? We don't know this. And again, how do we measure outcomes? What's the best outcome tool to use? So my bottom line again is treat your patient, not your imaging. This patient had no leg symptoms, had no leg swelling, had no flank pain or hematuria, no dyspareunia, and no pelvic pain. So it would have been inappropriate to, in my mind, to treat her aggressively, as her only complaint was itching and irritation in the vulva. So in conclusion, pelvic source veins of the in the pelvis, vulva, perineum, and thigh, they have a common anatomic source with the other cases you saw from Dr. Salazar, as we demonstrated in my patient's duplex exam, but they don't all need to be treated the same way, even if they have the same origin. These treatment methods vary, and we don't have good data to tell us which one's best. These disease-specific outcome measures that we talked about in Dr. Meisner's talk and Dr. Kalnani's are important. And we do always have to consider cost when we're treating patients, as well as what their symptoms are, and be responsible with their healthcare dollars. I'd like to turn the next talk over to Dr. Stephen Black from the UK.
Thank you very much, Kathy. That was fantastic. And I'm presenting a case here which is a male case because it's the best slides I had. But I think the principles here about cross-pelvic collaterals generated from any occlusive disease in the left leg are the point that we're going to address. So if you suspend the discussion about it being a man, but we look at the specifics of the discussion around pelvic collaterals coming from iliac outflow obstruction, I think that's where we want to get to. So this particular patient came with a primary complaint of varicosities in the leg, but did have some pelvic pain, and sometimes men do get that as a consequence of collaterals and have either gonadal or testicular swelling as a consequence, or you can find that they have collaterals in the groin region which cause them problems. But it is quite a common finding in women who've had previous history of DVT, where they do have leg pain, but also they have pelvic symptoms. And that's where the confusion comes in with nutcracker, pelvic pain, and leg pain, where these combination of symptoms may occur. So our practice is really to do duplex scan and MR venogram on any of these patients. And this particular patient who had varicose veins for quite a long time, we identified that he had pelvic outflow obstruction. And I have a very low threshold for doing outflow imaging in patients with a previous history of DVT who present with varicose veins or pelvic pain as their main symptoms. His Volta actually, interestingly, was 13 pre-op. So we therefore went and planned to treat his iliac outflow obstruction. My standard approach to these patients is to do a mid-femoral puncture. I think whenever you're treating anybody with any degree of iliac outflow obstruction, I think it's extremely important to avoid puncturing the groin as your direct puncture, because you miss collateral vessels that may be arising off the common femoral vein or profunda confluence. If there is disease in the common femoral vein and you miss that, it's probably the single biggest reason for reintervention and venous stents is missed inflow disease, which causes the stents to block or occlude. So I tend to go for a mid-femoral puncture, and you can see that in this particular picture, I square drape the leg, so I've got quite a lot of room to scan up and down the thigh to look for the best spot to puncture, because the anatomy is a bit variable, but normally you can find a place where the artery and vein provide you with an angle. And in the picture on the right, you can see the needle is highlighted in green. The vein is behind the artery, and you can go down the side of it and access the vein fairly easily. And then we go on to do a venogram. This venogram is a still run. You can see where the mid-thigh puncture is with the square drape that we're talking about there. These images were taken pre-COVID, before anybody decides to criticize me for not wearing a mask. Obviously, we'd have a mask on during COVID times, and I encourage you all to get your vaccines, etc. But you can see the origin of some cross-pelvic collaterals starting to come here. And the pattern of collaterals is quite variable, and actually a bit like everything else in venous disease, we don't have very good anatomical or other details about how collaterals form and what may cause problems. But this particular patient had ascending lumbar veins, which you see typically, but very big cross-pelvic collaterals. And if you delay the run, you can see that all the contrast was eventually draining across from the right-hand side. And I think in a female population who do present with pelvic symptoms, if this is happening in combination with pelvic vein reflux or any other features, it does produce quite a lot of congestion around the pelvic vasculature. And a lot of us have been having a fairly interesting debate about the origins of pelvic source pain, not only in venous patients but in other pathologies. And there do seem to be some plausible mechanistic reasons why patients with significant pelvic congestion can present with back pain and other features, which really do require significantly further research for us to understand pain in more detail. Once you've got this patient in this position, you then need to cross these lesions. This patient had quite reasonable inflow vessels, but what I do find quite useful for crossing these lesions is a Triforce catheter. You can see the tip of this here. It's a platform, and particularly when you have a normal vein leading into an obstruction, that can be quite tricky to get purchased in a lesion. And these systems really do help you to cross those and get a wire across, which is the main challenge. You can see here we're trying to get up to crossing into the IVC, and I find that the spinous processes are a very useful landmark for where you need to cross, because they mark the side of the IVC. If you ever wonder that you're ending up to the right of the spinous processes, you're probably going up vertebral spinal collaterals, and it's been well documented that you can end up in misadventure in crossing these chronic lesions. But you want to end up somewhere to the left of the spinous processes. You look at the screen, and the confluence of the iliac veins to form the IVC is fairly reliably just to the left of the spinous processes in the L4, L5 region. And one of the tricks I've really learned is using IVUS for a number of reasons. And particularly in chronic lesions, if you want to make sure you're in the right place, when you're inside the chronic obstruction and you're crossing all of that, you want to make sure that the artery is always adjacent to the area that you're crossing. And this will tell you that you're crossing in the right vessel and you haven't gone into a collateral, you haven't gone somewhere else, because the occluded vein still follows the normal anatomy. And these are the sort of additional checks you do to make sure that you've got your vessel in the right place. Stent sizing has become increasingly topically lately, and I think we're having seen 2 now venous stents withdrawn from the market for as yet not clear reasons, but certainly in the one there is concerns about stent migration. And stent migration is a factor of stent sizing in most patients and case selection. If you stent patients that really need a venous stent and you size the stent correctly, you're going to find that migration is something that is very, very uncommon to almost never in most practices. And I think it's something we really have to work hard at education and training of clinicians and everybody to support appropriate stenting in these areas. I try and find a normal segment of vein. In this particular patient, the external iliac was reasonably normal. And this is the IVUS of the external iliac, which was probably slightly bigger than you'd normally expect as a consequence of the obstruction on that side and being slightly under pressure. And so the minimum and maximum diameters here are 15 and 16, and I tend to take a halfway point between those and oversize by 2 millimeters. It's not evidence-based, but what I'm really relying on is the stent is slightly bigger than the vein you place it into, but not too much bigger, because you don't want to create a big transition from normal vein into stent, which probably does lead to thrombus lining the stent wall. And, you know, we still don't understand the origins of pain post-stenting, and it may be that stent sizing is a factor in this. And so in my practice, I've found anecdotally that when we have bigger stents, we tended to get more post-operative back pain than when we size stents closer towards the 14 range in these sort of patients. But this particular patient, I would put in a 16 stent based on that sizing. I think the external iliac is a bit bigger, but I'm trying to get a long length. I'm really trying to avoid going 18 or 20. And I think this is a change in sizing from wall stents to nitinol stents. They do behave differently, and you can't just take the sizing parameters from one to the other. It's not quite the same thing. Predilation is really important in all these cases. You can't place venous stents without predilating properly. And actually, dilating with a balloon gives you a good idea whether there's actually something going on there. Because if you blow up a balloon and there's no wasting, and the balloon doesn't hold in a nivel lesion, for example, then it probably doesn't need a stent. So you want to see some degree of fibrotic scar tissue that you're breaking up. The whole pathophysiology of May-Thurner syndrome was scar tissue associated with the iliac vein compression. It's not just the compression by itself. So, you know, Kathleen in the past has described a very good technique of Valsalvaing to see if the vein moves. And you could do that with IVUS. And when you do the Valsalva, if the artery lifts off the vein, you've probably got a normal vein. And if the vein wall itself distends, you've probably got a normal vein. And that's something that probably doesn't need stenting. I try and use a big balloon and pull it back through the obstruction. And this patient had a clear occlusion, so it's an obvious case. But if you're not sure, and you can pull a 14 or a 16 balloon under a little bit of pressure from the IVC to the common femoral vein without any restriction, then that patient almost certainly doesn't need a stent, because there's no obstruction to passage of a large balloon through that segment. And this, you can see there is our assessment of the vessel landing zone. Again, I do this a lot with IVUS, and you tend to find that the landing zone is slightly higher than you would think when you do it with IVUS than with venography. But here is the vessel that is overlying. I'll see if I can use a laser pointer here, which will probably be a mistake because I won't be able to turn it off, but we'll try that anyway. But here is the artery, which is this vessel here. This is the confluence of the common iliac vein as it joins the IVC, which is lying out here. And you want your stent to sit slightly proud of the artery, somewhere around here, because if you try and get too clever and land these nitinol stents right on the confluence, the overriding artery can roll off the edge of the stent and start to jail it again. So it's not about being massively too clever. You do need a little bit of overhang across to the IVC. And as we said before, the stent should sit just to the left of the IVC confluence and the left of the spinous processes. So you can see here where our stent is sitting. There's the spinous processes, and our stent is overriding just to the left. The contralateral wall of the IVC is always just lateral of the lumbar of the vertebral body, so you're not touching the other side. You can see there's still a little bit of wasting on the stent at that point, which need some post-dilation, but you can get that to open up if you've done your pre-dilation properly. And then you can see that at the end there with IVUS, that the stent is properly open and properly expanded. And I always check with IVUS before I do a venogram at the end of the procedure. At the May-Thurner crossing point, there's a bit of compression of the stent. With the open cell laser cut nitinol stents, you do see this from time to time. You don't necessarily have to do anything about it if the venous if the flow is good, but in some patients over time that can lead to problems. There is some discussion again about aspect ratio of venous stents and whether that is relevant. This is something we don't have enough data on yet to be sure, but most of the symptom change is going to be important. So you can see there the final venogram shows the contrast is flowing freely through the stented system. All those cross-pelvic collaterals have disappeared. You don't see the ascending lumbar veins anymore. And that's a good sign to me. I think it's important to do these runs with quite a lot of contrast. Venous outflow obstruction is a volume overload problem. So if you have a nivel patient as well, doing a simple hand injection may give you a false impression of what the collaterals are doing. You need that volume of flow to show you the collateral network if there is an issue. And there again is the sort of pre and post venograms with contrast hanging around in the first and finished in the second. Our follow-up for these patients is we follow up them day one with a duplex scan and a 2-week scan. And then we transition patients from low molecular heparin to Coumadin or warfarin at 2 weeks. If the duplex is fine, they have a split dose low molecular heparin for the first 2 weeks. And then I do regular interval scans to make sure that the stents stay patent in the first year. And then at 6 months, we consider a transition to a DOAC. Again, there's no guidance on this. I think the overwhelming point on anticoagulation is to make sure you have a consistent and solid regimen that the patients follow. They don't miss anything. And that's the end from me. And I'll hand back to Gloria for a talk on renal vein stenting.
Thank you so much. It was a great presentation. I absolutely agree with you. Education and placing of the stent in that location is key for outcomes and avoiding complications, particularly in the climate that we are right now with the current situation with the stents. So we just gave you an overview of heterogeneity of data and different presentations, and I'm gonna actually address a presentation that is very challenging, has almost less data than what we have already currently for pelvic venous disorders, but it's unfortunate and it's present in our spectrum of pelvic venous disease patients. So I almost wish I didn't want to see renal vein stenosis in these patients, but like Kathy Gibson said, if patients don't have symptoms, you should leave it alone. And that's sort of, I think, the first point that I wanted to make as I start my case. So this is the 47-year-old patient, multiparous, who has bilateral flank and back pain, left worse than right for 2 years, which is interesting. The pain is worse with standing and physical activity, 9 out of 10, and she's on narcotics. That's really bad sort of pain management for her. She is status post-hysterectomy, interestingly enough, for pelvic congestion syndrome, a couple of years back for pelvic pain. So she does not have the uterus anymore, but she has this left flank pain. In addition to that, she has persistent gross hematuria. And so she was referred to me for endovascular management of her presumed nutcracker. And she was not a surgical candidate. So one thing to be considered here, because we don't have enough data on this condition in terms of the treatment options and outcomes, it's always important to have a multidisciplinary evaluation of the patient. In this case, this patient had been seen by a surgeon and they were referred to me. So just a brief sort of presentation of left renal vein stenosis, nutcracker syndrome. It depends on the anatomy. We do have posterior, anterior, and circumaortic presentations. It presents more frequently in female, but I don't think we have sufficient data to actually support that. In my practice, I see very young patients, but I also see patients at a later age. So the physiology is simple. You can have either compensated or uncompensated stenosis leading to flank pain with hypertension, or with pelvic varices and pelvic venous disorder sort of symptoms, the pelvic venous congestion symptoms. Collaterals may present as well, and they may bleed into the calyceal system, which leads to the hematuria and the symptoms I already talked about. So here, so then you kind of can measure pressures in this situation. We usually do cross-sectional imaging, as you can see here, CTV reconstruction, and you can also have gonadal-vein reflux. So we already talked about the presentation. So this is a paper showing the extensive periurethral sort of veins causing sort of the hematuria symptoms. So I like this publication from 2009. I know it's not that recent, but I like sort of this algorithm the authors use in terms of the presence of left renal vein stenosis. And for me, that's very helpful. I think a patient who has severe classic symptoms with left flank pain and hematuria should definitely be evaluated at least for surgery first. And then if a patient is not a good candidate, then we can approach it endovascularly. However, if you have patients with varicocele and pelvic varicosities presenting with pelvic congestion, I think that it's important to know that, and I have done that, if they have varicocele and varicosities, gonadal vein embolization may be an option, and those patients do improve with that. Now, again, this is what I do in my practice, and we still need data to support it. Of course, if patients have mild symptoms or typical symptoms, I would leave it alone. This is a patient that is different than the one that I just presented. She actually presented with pelvic pain, so pelvic venous disorders secondary to renal vein stenosis. You can see there's a collateral here as well as a gonadal vein reflux. So we staged this treatment. We embolize the gonadal vein with coils, but you can appreciate a little bit of the stenosis here and with the collateral. So this patient actually ended up having to have a stent because she had persistent symptoms. And I know we've discussed prior to this webinar, we had so many discussions this year in different sort of conferences that sometimes you may need to do that. The issue though is what we already talked about is the technique, proper sizing and proper stent for dislocation. And do we even have the data to support this? So this was a wall stent. I don't think the wall stents are perfect. I mean, honestly, I'm shying away from stenting at this point only if it's necessary. And even nowadays with the dedicated venous stents, I would choose probably a nitinol stent to use. I think the wall stents are a little problematic in this anatomical location, sizing and migration, etc. So going back to my patient, again, she only has left leg symptoms because she already had a hysterectomy. You can appreciate the collaterals here with the venography. So I elected to go from a transjugular approach. And so what we end up doing, so here's the venography. And so I ended up trying to get into the gonadal vein just to kind of advance my vascular sheath because those patients have stenosis, so it's difficult to catheterize the renal vein. I think that's sort of part of the challenge here. And also it's a short segment of a vein that is stenotic. So you want to kind of size your stent and have a proper sort of anchoring, if you will, distally in the renal vein. So here's my run from the gonadal vein, and then here's my run from the sheath. And then I elected again to do a wall stent. This was a couple of years back. And, you know, I had a challenge in the procedure because the wall stent actually moved a little bit into the IVC. So I ended up putting a balloon and just kind of pushing it in. And this is the final result. You know, I guess I got lucky, but, you know, and this is the IVUS again, you know, the measurement. I do use IVUS. I kind of measure pressures in this situation, but I think, you know, it can be a little bit deceiving. And so I use the IVUS just to want to make sure that the proper sizing. And here's the final result of this patient. Now, this patient did it, and you see like the stent is a little bit more towards the renal vein now, as opposed to in the beginning where I actually migrated a little bit to the IVC. Now, I chose this paper to kind of talk about long-term outcomes. We don't have enough data. And for me, this patient did improve the hematuria 100%. Her pain improved to a 50%. It wasn't 100% improvement. And so I think, again, we still need to kind of learn with this patient population, particularly when there's mixed presentations, left leg pain plus pelvic congestion. And here in this paper, the stenting resolved most of the symptoms. I think that a subset of patients did not have any sort of in this paper sort of good outcomes. And I think the jury is still out for these types of conditions. And I think we still need to look carefully. There's also surgical options. So I think we still need to kind of evaluate those patients and have more data. So in summary, renal vein stenosis can be associated with left leg pain in the setting of pelvic venous disorders, as well as with pelvic congestion. But management will depend on patient symptoms and surgical pre-evaluation. And I think this is extremely important given the paucity of data in this condition to have a multidisciplinary team evaluating these patients. That said, in my practice, if the patient presents only with pelvic venous pain in the pelvis, I would only do left ovarian vein embolization, but sometimes stenting may be needed in cases of renal pain and hematuria associated. And again, there's low level of quality of data to support stent. However, future studies are needed to understand which patients will benefit the most. Thank you very much.
Thank you, Gloria. That was perfect. And maybe I'll start with a question, both for Gloria and Stephen can chime in too on it. You know, I think part of the problem with stenting for renal veins is we really don't know and don't have an ideal stent for it. It's, I think several people have now operated on wall stents, which just tend to be too rigid. And I think several people now have reported and seen it doesn't take that curve into the retroperitoneum very well, and then erodes into the anterior wall of it. And I think part of that is a misconception about nutcracker syndrome, in quotations, in that, not only, or even in some cases not at all, is it compression by the SMA, but really it's that stretching as the renal vein takes that transition from sort of posterolateral in the kidney to anterolateral when it joins the IVC. And I personally have even avoided the dedicated venous stents just because I think they're a little bit too rigid, and have gone with, I usually use an arterial nitinol stent. And as Stephen showed, you usually do get some compression with that aspect ratio thing with an arterial stent. But like in the iliac vein, seems to do okay. So Gloria, what do you think the ideal stent should be for a renal vein?
So I think that definitely, it's been a couple of years that I kind of wanted to shy away from placing stents altogether, and kind of have the patients have a surgical evaluation and see if this is an option. But if you have to place a stent, definitely not a wall stent. I think I've learned that. And yes, nitinol stents, 14 millimeter. I agree that even the dedicated venous stent may not be even sort of like an option. I do think, though, that sizing is important. It's a short segment of a vein. I mean, you have to have some space to kind of anchor the stent, if you will. And also, I think if we're talking about pain, like post-procedural pain with stenting in the pelvis, I do think that this is also another factor to consider. How are these patients going to sort of evolve or sort of during the upcoming years, if the stent, can cause any damage. And I think we know, like you mentioned, the erosion, et cetera, and we don't know that. So I think we still have a lot of work to do.
Yeah, I think that's quite right. I mean, Mark, my ideal stent is not to stent the renal vein. I think at the moment that's where I would sit on that. I don't think the venous nitinol stents have not been designed for that, and you have to put a short stent into the renal vein because of the length of it. And I think there's a couple of things that happen with that. Short stents are not nearly as flexible as a longer stent. If you just play with them on a bench, they're much more rigid because they're shorter metal, which is natural. They're much more likely to migrate until they've epithelialized. And I think that's a risk from renal vein stenting. And I think the points that Gloria has really well made and you've alluded to is we don't really have robust diagnostic criteria for nutcracker syndrome if we want to stick with that name. And a bit like May-Thurner syndrome and the others, we probably need to move away from that. But there is some normal compression. There is some stretching of the anatomical location of the kidney. It's not always just a compression. So I think we struggle with it, and putting a stent in, it sometimes looks good, but it's not ideal. So my practice, we tend to do the transposition. And then if they often need a stent afterwards because they get stenosis. And I think the two approaches that are what Peter Glevitsky has advocated, which is suturing the stent in and doing it at the time of your procedure. So it's not going to migrate or go anywhere. But I tend to use a covered arterial stent afterwards if I do put a stent into the stenosis that forms afterwards because of the reasons you've alluded to.
And I think that's a really good approach, Stephen. My general algorithm is in young patients with pelvic symptoms, primary pelvic symptoms, we'll do a gonadal vein transposition. If they have flank symptoms, just because of the stenting issue and particular compression, we tend to treat those with autotransplantation now. But older patients, particularly in their late 40s, 50s, 60s, I think stenting is a reasonably good option for older patients, not for younger patients who I think are best served with surgery. So with that, Steve, let's move on to the issue of back pain. And I know this has been a discussion quite a bit of late. And the only data out there, which really comes from one series specifically reporting it, showed no relationship to stent size. And then both the Raju's series describing buttressing stents with C-stents and Rossi's randomized trial also reported that the back pain was always transient and even with stents up to 22 millimeters. So is there really a relationship between stent size and back pain?
Oh, Mark, that's a great question, and I think it's difficult to answer that, isn't it? Because the data quality, even with those few studies, is not great. Is it? The studies were using a heterogeneous group of stents, different patients for different reasons, and I think it's difficult to be entirely clear on this. I think in my own practice, anecdotally, I could almost always pick the patients that had bigger stents the morning after the operation, even if I hadn't looked at their notes, and we have a broad group of people doing these, when they complained of pain, because it did seem to be related. And maybe the nitinol stents are different because the pressures are different to a wall stent. The forces are stretch forces, and those do cause nociceptor type pain, and there might be some pain that has come from a perivenous bruising or hematoma formation when you break that fibrotic scar tissue up in patients that need it. There must be something, and the pain is probably reflected pain rather than genuine back pain, which I know we are having conversations about, and I think we need some proper work on understanding pain. I think it's hard to say what the main cause is. In terms of an argument against stent oversizing, I think there's a number of different reasons not to oversize stents, and it's not just about pain. So I don't think saying pain is not related to stent size then says, well, it's absolutely fine to put a 20 stent into the iliac veins. I think there are other things that are conceptually going to go wrong with too big stents in the iliac veins over time, not least thrombosis or cutting through the vein wall, tenting, straightening, and all the other things that we see. But we do need a better handle on pain. And I think both back pain and groin pain, to understand why they get it. Most people, it's transient. So for the vast majority of patients, I warn them they'll have back pain for a week or two and it'll go away. And that's pretty consistent. But there are some patients who get persistent pain, and that's a very difficult thing to deal with, because then the questions start coming, can you explant my stent? And a bit like nutcracker pain, we know there's patients who end up losing their kidney and the nutcracker pain doesn't go. So the understanding of what's driving the pain has got to be really clear, because you get caught in really difficult conversations with patients when the stent becomes the focus of the driver for pain.
Great answer, Stephen. I'll ask you both another question related to that on stent sizing. So, you not uncommonly see a patient who has a fairly tight nibble, and then more peripherally, the common iliac vein will be dilated. And so you have a patient, say, who has a nibble lesion that is a real nibble lesion. Like you say, Stephen, you put the balloon up, it shows a clear waist there. You can't pull a 14 millimeter balloon through it, but the proximal common iliac vein measures 20 millimeters.
Yep.
Is the best approach to size the stent appropriately to the 20 millimeter vein, or to downsize the stent, anchor it in the external iliac vein, and leave that big gap, which aesthetically is very displeasing? I don't know physiologically if it's in that dilated common iliac vein. I'll ask you first, Lori, and then Stephen can
Yeah, no, I think that's when you have a severe stenosis, I think that's an issue for sure. So I usually just extend it below, like just size it to past the internal iliac, and then, deal with it. It doesn't look good. And then I try to sort of dilate it, but it's definitely an issue, because you're then oversizing from a measure that is not a baseline. It's a disease sort of vein, if you will, from the post-stenotic.
Yeah, Mark, I agree with what Gloria just said. So if we take the analogy of aneurysm disease, which we all understand, you don't size an EVAR for the aneurysm, you size it for the normal neck above and below. So I don't understand why we would then go into veins and size for a pre-stenotic dilated common iliac vein, which is bigger than it should be, and determine that we need to put a stent for that size of vein in that vessel. And I think it does lead to a bunch of technical questions about how the stent will sit and size. So my practice is to size the stent for the normal segment of external iliac vein, and I routinely extend the stents into that and around the bottom bend in the pelvis, because I think the stents sit better, you get better flow through that stent. And actually, when I've screened these patients later, and we saw some of this coming out of a number of the IDE studies, the common iliac vein remodels around that stent over time. And I had a really good case that showed this to me, which was a patient presented with a DVT in an external iliac vein that had become 4 centimeters because of a tight stenosis above and a stenosis below. And I lysed that patient and stented them, fully expecting to have to do something about the aneurysmal segment of external iliac vein. And within 48 hours, that vein had shrunk down around the stents and we didn't need to do anything. And I followed that patient up for a year, and the vein looks normal now, and it's completely normalized around the stent. So I think if you have pre-stenotic dilation, the vein, once you decompress it, comes back down to normal size. You just have to follow them. Now that's anecdotal. I have no evidence for that before I get shot. But at the same time, I think we just got to be super careful about sizing on abnormal segments of vessel. We don't do that in any other field of vascular surgery, and I don't see why venous would somehow be the right thing to do.
So, and just to touch on it, with these recent stent recalls, is this a stent problem or an operator problem or a diagnostic problem?
I think overwhelmingly this is a technical training problem for operators of how you place stents safely. I think in high volume centers with experienced users, the number of migrations reported is infinitesimally small. And you saw that from the IDE studies. Out of 1,000 patients, only Cook reported a single episode of stent migration, with a very strict criteria of migration being more than 1 centimeter of movement, which virtually no one else is even going to report. The only other migrations we'll ever see are stents that have moved to the heart, pretty much. So I think it's very, very unusual if you place stents correctly. And I don't see this personally as a stent problem. I see this as a teaching and training and education problem.
Great. Well, thank you, all of our panelists, Stephen, Gloria, and thank you all for joining us for this webinar, and for Medtronic for sponsoring it. Everyone have a good afternoon. Thank you.
Thank you.
Thank you.